Welcome to today's deep dive. We are tackling a topic today that fundamentally reshapes human demographics and the very systems we rely on to survive.
Yeah, it really does. It's massive.
It is. So today our mission is to unpack an official January 2026 departmental update from the World Health Organization. We're specifically looking at the outcomes of the 6th Global School on Refugee and Migrant Health.
Right, which just wrapped up recently in Geneva.
Exactly. And to set the stage for you, I want to start with just a staggering statistic straight from the source. Right now, today, there are over 1 billion people on the move worldwide.
Wow.
Yeah. And out of that profound number, 117 million people are forcibly displaced. Okay, let's unpack this. Human migration is permanently altering global health systems, and today we're looking closely at how countries are actively trying to fix the fractured, honestly, often chaotic state of care for these populations.
It's just a phenomenal scale to consider. When you have 1 in 8 people globally on the move, you are no longer dealing with some niche issue.
Right.
You're dealing with the defining characteristic of the modern human experience. So the objective of our deep dive today is to explore the strategies discussed at that Geneva event, which, by the way, brought together 1,200 participants from 143 countries.
Huge turnout.
Huge. And the report focuses heavily on 3 critical areas that are necessary for building migrant-inclusive health systems. That's bold leadership, primary health care, and mental health, alongside psychosocial support.
And for anyone listening who works in health, public policy, or just pays attention to the global shifts, the old model of merely setting up a medical tent at a border crossing is entirely obsolete at this point.
Completely
We're
obsolete.
looking at permanent displacement, which means host countries are suddenly absorbing, decades of untreated chronic conditions. Understanding how health systems adapt to this reality is crucial, really, because structural failures in healthcare eventually impact everyone living within that system.
Absolutely. The baseline problem that the WHO update outlines is incredibly complex. Refugees and migrants face this absolute gauntlet of hurdles when they try to access care. Yeah. We're talking about strict legal barriers, severe linguistic disconnects, financial constraints, and just profound social obstacles. And when you combine all of that, it leads to highly fragmented services. People simply fall through the cracks.
They just get lost in the system.
Exactly. Add in the current global healthcare workforce shortages and significant governance gaps, and achieving any kind of continuity of care becomes an immense logistical challenge.
Which paints a pretty grim picture. But the report does highlight a strategic shift in how institutions are approaching this. It's spearheaded by a quote from the WHO Director General, Dr. Tedros Adhanom Ghebreyesus.
Yes, a very pivotal quote.
He stated, "The health challenges faced by refugees and migrants cannot be addressed through humanitarian action alone." He pointed out that the WHO is now focusing on supporting countries to build the capacity to develop sustainable, equitable services.
If we connect this to the bigger picture, what Dr. Tedros is signaling is a systemic paradigm shift. For decades, the global response to displaced populations has heavily relied on emergency humanitarian action.
Like short-term funding cycles.
Right, short-term funding, temporary NGO clinics, immediate crisis management. But what the WHO is emphasizing now is that you cannot put an emergency Band-Aid on a permanent structural reality. We have to transition from temporary relief to fully integrated health systems that treat migration as a constant, predictable factor.
And the report doesn't just leave that as an abstract concept, discussed in a conference room in Geneva. They highlighted real-world examples where this kind of systemic leadership is turning into action on the ground.
Yeah, the country examples were really fascinating.
Let's look at Colombia. They have scaled what they call territorial health committees, which are designed to coordinate multi-hazard responses and manage cross-border health services. But I'll be honest, whenever I hear the word committees, I immediately picture endless bureaucratic meetings that don't actually change anything on the ground. How are these groups actually functioning?
It's a fair skepticism, for sure. Committees often become echo chambers. However, the territorial health committees in Colombia are designed entirely around decentralization.
Okay, decentralization.
Yeah, instead of waiting for the capital city to dictate how a sudden influx of migrants should be handled at some remote border town, these local committees have the authority and the budget to respond immediately.
Oh, that's a huge
It
difference.
changes everything. They assess the specific geography, the local hospital capacity, and the immediate multi-hazard threats. Whether that involves infectious diseases or just resource shortages, they deploy resources right there at the territorial level. It shifts the power to the local actors who are actually managing the flow of people.
That makes a lot of sense. And speaking of geography, the logistical achievement highlighted in Kenya and Somalia really caught my eye.
Oh, the border initiative.
Yeah. They share an 800-kilometer porous border. The challenge of delivering consistent health care across that kind of vast, unregulated landscape just seems nearly impossible.
Yeah.
Yet they implemented transit point vaccinations and are tracking what they call zero-dose children.
Which are kids who haven't received a single routine vaccination.
Right. But tracking a family in transit across a desert border seems logistically unfeasible. How do they actually execute that?
It requires changing the fundamental nature of what a border checkpoint is. Typically, border crossings are strictly viewed through a security or a customs lens, right?
Passports, contraband, that sort of thing.
Exactly. But Kenya and Somalia utilized actionable leadership to integrate health protocols directly into those transit points. They essentially set up health outposts where people naturally bottleneck during transit.
So they just wait for the natural choke points.
Right. When families cross, health workers are stationed right there to check vaccination statuses and administer vaccines on the spot. By coordinating this data across that specific 800-kilometer stretch, they're catching highly vulnerable children before they disappear into a new country's interior. It's a profound public health victory that prevents outbreaks of diseases like measles or polio.
That is incredible. Over in Vietnam, they tackled the governance gap by creating an interministerial migrant health working group. But again, I hear interministerial, and my brain immediately goes back to red tape. Did the report give any indication of how they actually get the finance, legal, or transport sectors to care about health policy?
They get them to care by demonstrating that health policy fails without them. You can't get a rural migrant worker to a specialized clinic without the transport sector ensuring there are bus routes. You can't fund these clinics without the finance ministry allocating the budget.
Right, it's all interconnected.
Exactly. You can't guarantee an undocumented worker will even walk into a hospital without the legal sector providing protections against immediate deportation. Vietnam's working group acknowledges that migrant health is not just a problem for the Ministry of Health. Baking migrant health directly into broader national frameworks requires forcing these separate silos to communicate and share responsibility.
Dr. Santino Severoni, the head of the WHO Special Initiative on Health and Migration, summed this up perfectly at the event. He noted that leadership is what transforms evidence into action. It requires implementation, accountability, and the courage to innovate, collaborate, and listen to the voices of refugees and migrants themselves.
Courage is the operative word there. Professor Paul Spiegel from Johns Hopkins University added a really stark layer to this discussion during the event. He pointed out that in settings where refugees and migrants are living within fragile health systems, leadership is literally the difference between a coherent, humane response and total chaos.
Total chaos.
Because in a resource-constrained environment where hospitals are already struggling to treat their own citizens, strong governance is the only thing holding the entire system together. Without it, the system just collapses under the added weight.
Okay, here's where it gets really interesting. Because if interministerial committees and territorial frameworks are the blueprint, what happens when a displaced person actually walks up to a clinic door?
That's the real test.
Exactly. All that top-down leadership doesn't mean much if the front line is broken. The report positions primary health care, or PHC, as the absolute foundation of inclusive, people-centered health systems.
Primary health care is the vital intersection where the theoretical health system meets the actual community. The source material provides brilliant examples of local, inclusive solutions that bypass traditional barriers. Take Thailand, for instance.
What do they do?
They didn't just instruct migrants to navigate a complex transport system to find some distant hospital. They embedded a health center directly inside a migrant community. And crucially, it was co-led by volunteers from that very community. The result was a significant boost in immunization coverage.
So it's not just about building a structure closer to them, it's about who is inside that structure. Having a clinic run by familiar faces must completely alter the dynamic.
It does. It completely removes the intimidation factor. Navigating a foreign medical system is terrifying, especially if you face language barriers or fear authority figures. By utilizing community volunteers, Thailand bypassed the cultural friction. Trust was already established, which made the delivery of clinical care seamless.
Jordan took a slightly different route with their healthy community clinics. They didn't just build separate, isolated facilities for refugees. They expanded these clinics from within their Ministry of Health. Does that mean a refugee is tracked the exact same way as a citizen?
That is the ultimate goal of institutionalizing inclusive care. Jordan paired the actual delivery of services with capacity building and data gathering within their national framework.
So it's all one system.
Exactly. When you integrate migrant health data into the National Ministry of Health database, a displaced person receives the exact same tracking, follow-up, and continuity of care as a local citizen. It prevents the creation of a parallel, inferior health system that relies entirely on unstable NGO funding.
We also see innovations happening in Europe. In Brescia, Italy, they set up a specific clinic to fill a critical gap for undocumented migrants. They provide free consultations and continuity of care for chronic conditions.
Which is so important.
But whenever undocumented care is brought up in policy discussions, the elephant in the room is always the cost and the political friction. Did the report address why an overstretched European health system would prioritize this?
It comes down to pure health economics and systemic efficiency. Often, undocumented individuals avoid seeking medical help due to fear of deportation or exorbitant costs, waiting until they are in a dire, life-threatening crisis.
And then they end up in the emergency room.
Exactly. And emergency room care is exponentially more expensive and resource-intensive than primary care. By providing a safe primary care clinic for chronic conditions like managing a patient's diabetes with regular insulin and checkups, Brescia is keeping people healthier, preventing those catastrophic emergency room visits, and ultimately creating a much more efficient use of the city's medical resources.
So, what does this all mean? We have embedded clinics in Thailand, integrated national systems in Jordan, and specialized preventative care in Italy. How does this tie back to the big picture of global health for the listener?
Well, Dr. Sham Syed, the head of WHO's Service Delivery and Primary Healthcare Unit, pointed out that primary healthcare is the structural backbone of these migrant-inclusive systems. But the real synthesizing insight comes from Dr. Ahmed Zoutin, the WHO representative in Libya and Tunisia. He delivered this powerful assertion. When we build migrant-sensitive health systems, we build systems that are stronger for everyone. Compassion is power.
Compassion is power. That completely reframes the narrative from being an act of charity to an act of structural fortification.
If you think about it in terms of stress testing the system, his point becomes incredibly clear. If your primary healthcare network is flexible enough, culturally competent enough, and accessible enough to successfully treat the most marginalized, vulnerable, and highly mobile populations on Earth, then that system is immensely resilient.
That makes total sense.
Right. A health system capable of managing the complexities of an undocumented migrant with a chronic condition is a system that will inevitably provide better, more adaptable care for the host community as well.
A system that works for the most vulnerable works better for everyone. That brings us to the final area discussed at the Geneva School. We've covered leadership and physical frontline care, but we have to address what is often the invisible crisis: mental health and psychosocial support.
The WHO firmly established at this event that access to mental health care for displaced people is a fundamental right, not an optional privilege or an afterthought. Devorah Kestel, the director of the Department of Non-Communicable Diseases and Mental Health at WHO, was unequivocal on this.
What did she say?
She stated that mental health is essential to universal health coverage. No system can realistically be considered inclusive if mental health is neglected. You cannot claim to provide comprehensive health care if you are only treating physical ailments while entirely ignoring the deep psychological trauma associated with forced displacement.
The psychological toll of leaving everything behind, often under extreme duress, is immeasurable. The report dedicated time to a film that won an award at the WHO Health for All Film Festival called Dalal's Story. Why did the WHO feel the need to highlight a film at a policy and systems conference?
Because policy conferences can easily get bogged down in dry statistics and bureaucratic frameworks. Dalal's story, along with personal testimony shared at the school, was utilized to ground the policymakers in a deeply human reality. Before you can even attempt to provide clinical psychiatric care, you have to overcome formidable barriers of fear, cultural stigma, and profound distrust. The film illustrated that you must make the care dignified and culturally safe, or the populations who need it most will simply hide from it.
Overcoming that stigma requires highly intentional strategies, particularly in active crisis zones. The source material details how psychosocial support is being actioned in some of the most challenging environments on Earth. In Gaza, amid mass displacement and severe conflict, UNRWA has been working to strengthen psychosocial support. When traditional clinical infrastructure like hospitals and psychiatric offices is under extreme pressure or entirely destroyed, how do you actually deliver that support?
You have to lean on the social fabric that remains. In Gaza, UNRWA focuses heavily on community networks. When you lose the physical building of a clinic, the community itself becomes the delivery mechanism for psychological first aid.
Wow.
It involves empowering teachers, community leaders, and local volunteers to recognize trauma responses and provide immediate emotional support and coping strategies to those around them. It's a resilient web of care that operates even when formal infrastructure fails.
We see a similar reliance on community adaptation in Somalia. They are integrating mental health directly into primary care through a process called task sharing. Task sharing. Having non-specialists handle mental health sounds risky. Are they having community volunteers act as clinical psychiatrists?
It sounds counterintuitive, but think of it like basic first aid or CPR. You don't need a board-certified cardiologist to perform chest compressions to save a life, right?
Right, you just need a properly trained bystander.
Exactly. Task sharing does the exact same thing for mental health in under-resourced areas. You train non-specialist health workers like primary care nurses, midwives, or community health volunteers to deliver basic foundational mental health and psychosocial support. They learn to identify severe depression, offer structured counseling, and manage basic interventions.
And then what about the severe cases?
You reserve the scarce, highly specialized psychiatrists for those most severe, complex clinical cases. By upskilling the frontline workers, you exponentially expand the reach of mental health services.
That analogy clarifies it perfectly. You meet the patient where they already are, utilizing the workforce you already have. The report also stressed that as we expand these innovative services, we must close the digital health data gaps. If we aren't tracking who needs what or evaluating which interventions are actually working, we lack visibility and accountability.
Without metrics, you are flying blind. Data is the engine that drives sustainable funding and allows for real-time policy adjustments. However, even with perfect data systems, fully funded clinics, and expertly trained staff, there is a foundational prerequisite that cannot be skipped or rushed.
That brings us to a really poignant insight shared at the event by Dr. Wahid Aryan, an NHS physician and UN SDG goalkeeper. He speaks from both lived experience as a former refugee and his current role in clinical innovation. He told the attendees, start with trust, reduce fear and stigma through community engagement before clinical care.
What's fascinating here is the required order of operations. We often conceptualize healthcare as beginning the moment a patient interacts with a receptionist at a clinic. Dr. Aryan is pointing out that for marginalized populations, people who may have fled persecution, who may be undocumented, or who have experienced severe trauma at the hands of state authorities, the healthcare intervention must begin long before the clinical setting.
It's about relationship building.
Absolutely. Community buy-in is an absolute prerequisite for clinical intervention. You could construct the most technologically advanced hospital in the world, but if the local migrant community fears the authorities running it, the hospital is useless to them. Trust is the ultimate non-negotiable currency in migrant health.
Trust is the ultimate currency. That beautifully encapsulates so much of what this sixth global school was trying to achieve. To bring all of this together for you listening, we've explored three inseparable components today. First, bold leadership that moves beyond temporary humanitarian band-aids to create sustainable cross-border and interministerial policies that actually function in reality.
Second, primary health care that acts as the accessible, community-embedded backbone of the system, proving that treating the most vulnerable makes the whole system stronger. And third, mental health and psychosocial support, recognizing that invisible wounds require just as much systemic care and innovation like task sharing, built entirely on a foundation of trust.
And the overarching message delivered in Geneva is that these components cannot exist in isolation. You need the top-down leadership to legally protect and fund the primary care clinics. You need those frontline primary care clinics to deliver the task-shared mental health support.
It's all connected.
It is. Concrete country experiences from the decentralized committees in Colombia to the embedded volunteer clinics in Thailand to the transit point vaccinations in Somalia prove that there are scalable, practical approaches to close the structural gaps in global care. Whether you are looking at how your own local neighborhood clinic operates or reading international news about complex border policies, health outcomes are deeply intertwined. The health of a displaced population and the health of a host community are not two separate competing interests. They are one shared, undeniable public health reality.
This raises an important question, and it's something I want you to mull over after we wrap up today. If over 1 billion people are currently on the move globally, and human migration is not a temporary crisis but a permanent reshaping force in our world, how might our very definition of a national health system need to evolve in the coming decades?
That's a huge shift in perspective.
If human beings are constantly crossing borders, what does a truly borderless approach to human well-being look like?
That is a brilliant question to end on, a borderless approach to well-being. Thank you so much for joining us on this deep dive into the WHO's update on global health and migration. We loved unpacking these sources with you, and we will catch you on the next deep dive.